Let us start with us with an emerging and a promising field to explore and research, and the Royal College really make a spotlight on the genomic field. They create two talk articles spotlight on genomics and newborn screening and the role of genomic testing, what obstetrician need to know, which is very important topic, a promising field. We will try to summarize and be condensed, and by the end of this video you will find a link for a question bank, and you can, if you want to more practice for questions, you can request in private for more question. Okay, we will start by what is the genomic tests are used for, when they are used, how results affect counseling, management, and ethics. This is the questions will be answered in these talk articles. Uh, what is currently known, the prenatal screening, maternal age alone, detection rate is 30% for trisomy 21. Combined first trimester screening, detection rate is more than 85%, with false positives 5%. Non-invasive prenatal testing, or NEPT, uses cell-free fetal DNA from the maternal blood, and sensitivity and specificity more than 99% for trisomy 21. Major reduction in invasive tests like amniocentesis and chorionic villus sampling. All this what currently we know. What is the limitation and the important counseling issues regarding the genomic confined placental mosaicism, which can cause false positives or discordant NEPT and chorionic villus sampling results, is very important in counseling issues, especially in part 3 MRCOG. Amniocentesis is more representative of fetal genotype than chorionic villus sampling. What about the ethical considerations? Very important as well for counseling. High uptake of NEPT raises issues of reproductive choice, disability rights, societal pressure. What is beyond aneuploidy? Diagnosing fetal anomalies, genomic testing for structure anomalies, stepwise approach. PCR karyotype, chromosomal microarray, trioexome sequencing, diagnostic yield up to 80% for selected ultrasound anomalies, up to 90% in non-immune hydrops fetalis. What about the clinical impact for the prognosis, recurrence, target pregnancy management? For the non-invasive prenatal diagnosis for monogenic disorders, NEPT is a screening. It's a key for the exam. NEPT is a screening for aneuploidy, and in neonatal invasive prenatal diagnosis is diagnostic for single gene disorder. What about the detecting conditions like cystic fibrosis, achondroplasia? Also used for fetal sex determination for sex-linked disease like hemophilia, fetal RH genotyping targeting anti-D prophylaxis. What about the pre-implantation genetic testing? Structural chromosomal arrangement and reduced miscarriage risk. Also monogenic disease like thalassemia, sickle cell disease, and BRCA mutation. A promising field to explore and research, and the college high yield about this topic, which is cancer genomics. It's very important to be aware, at least, ovarian cancer, BRCA1 and 2, guide inhibitor therapy, combination, maintenance therapies improve progression. For the cervical cancer, small subgroup is HPV independent associated with the other mutations, oncogenic mutations, worse prognosis, future role of targeted therapy. Also, endometrial cancer, non-invasive molecular sampling, risk stratification diagnosis using genomics, Lynch syndrome. Prevention and risk stratified strategy for Lynch syndrome. We know universal molecular screening of endometrial cancer enable cascade testing and cancer prevention. For like risk reducing surgery, BRCA carriers consider bilateral salpingo-oophorectomy after childhood after childbearing. Lynch hysterectomy plus or minus bilateral salpingo-oophorectomy. Average risk women avoid unnecessary oophorectomy less than 50 years, more than cardiovascular risk and bone risk, cognitive risk. What about the emerging areas for genomics, which is very important to be aware and know about it? For the male infertility, genomics may refine diagnosis beyond semen analysis. Preterm birth pharmacogenomics may predict progesterone response as well. It's very important, but still under touch. About the question bank, we will take a sample from the question bank and you will find the link of my question bank for more practice. Which factor most commonly explain discordant and invasive testing results? It's very important. Try to guess what is the answer. Okay. Correct answer is C. Confined placental mosaicism. The other topic which is related to the spotlight, newborn screening and the role of genomic testing, what obstetrician need to know. It's very important what obstetrician need to know. The blood spot in UK newborn blood spot screen for 9 serious conditions. It can be a tricky MCQ or SPA. They are performed day 5 of life. Biochemical and hematological test. It's not a genomic. Uptake 97%. Screened for which condition? Congenital hypothyroidism, cystic fibrosis, sickle cell disease, and the 6 inherited metabolic disorders. Of the most famous metabolic disorder is screening for phenylketonuria or PKU. It's a tricky MCQ as well. Okay, this is what is offered now. Like why change is needed? Big problem. 6,000 to 8,000 rare disease, 80% are genetic, many children diagnosed too late after irreversible harm. It's very critical. This is a problem. 800 rare genetic diseases are treatable if detected early. Traditional screening detects metabolites or biomarkers. Misses many genetic disease. This creates a rationale for genomic newborn screening. What is genomic newborn screening? As a definition, we have to define its use of whole genome sequence at birth to screen for serious, early onset, treatable genetic conditions. Why whole? Sequence coding and non-coding DNA can screen many conditions simultaneously, allows future reanalysis as treatment emerge. What is the generation study? We can go through this. What is not reported? Adult onset condition, career status, variant of uncertain significance. A big issue, especially in part 3, which is the consent, how consent works. Parents are informed antenatal. Consent is taken before birth. DNA obtained from the umbilical cord. All these are keys for MCQs and for counseling in part 3. Data stored until child is 16 years, then reconsented. Ethical tension, parent to consent on behalf of an asymptomatic child, and you have to give a balance between the benefit of early treatment, child future autonomy, data privacy, and equity. Very important and challenging. Also, you have to be aware that the consent of the parent supposed to be optional, and the parent supposed to be aware that their consent is optional, it's not obligatory. What about interpreting the result is expected outcome? 99% no actionable finding, and 1% only condition suspected result. To what happened after this step? Refer to NHS specialist team. Non-genomic confirmatory tests, biochemical, enzyme, imaging, genomic result alone never starts treatment, as we can consider it as screening tool. It's not a confirmatory diagnostic test. What about the challenges and the limitations? Scientific variable penetrance and expressively asymptomatic newborn lack phenotype, limited diversity in genomic database, ethical equity of access of potential and anxiety, and cost effectiveness and follow-up burden. What about our rule? As an obstetrician, you are not expecting to interpret genomic variants, you provide genetic counseling alone. You are not alone. You are expected to understand the purpose and limitation of genomic, support informed antenatal decision making, work with midwives, neonatologists, and genetic teams. You are a team, it's MDT team. You are not alone. Again, our question bank, you can see and you will find a link of question bank. Which of the following best describe the current UK newborn blood spot screening? Okay, I will give you a chance to watch the video slowly to discover the answer. They are screening currently for 9 conditions using biochemical hematological methods. Whole genomic screening is not part of routine screening now. This is the current condition now. Okay. What about our home message? Newborn screening in UK currently relies on biochemical tests for 9 serious conditions. This is the current genomic newborn screening using whole genome sequences that has the potential to identify a wider range of treatable childhood onset genetic condition earlier, improving. This is our reference from the TOG article of the Royal College 2025. Thank you. You will find a link for the question bank. Also, there is a special question bank for the PCR. If you are interested, just send me a comment or request on the comments to send to you privately. Okay, thank you.